Well, good evening and welcome to the AMA WA and WA Health webinar on COVID-19. Welcome Andy Robertson from the Department of Health, who's kindly given us his time this evening amidst all the other demands that he has going on. It's a very full-on time for him, and we really appreciate that he's prioritising the need to communicate directly to the profession about the next steps. It's been an important day in the history of the evolution of this in Australia. So we're not going to waste his time. We'll get straight into it, or your time, and we'll try and make it interesting for you and get you as up to date as possible so that you feel like one of the insiders. So that'll do for introduction, and I'll ask Andy to run us through his slides now. We won't spend a lot of time on the science of it because I know that all of you will have been following that in a pretty keen fashion, but we'll talk about his insights into it and then get on to our response. So thanks, Andy. I'll hand the clicker over to you. Oh, that's a picture of me, which is very important.
Okay, good evening, everyone. So I'm going to give a couple of quick slides on just a bit of background and answer a few of the questions that came up before this. Coronavirus is a large family of viruses, as you're aware, responsible for SARS, MERS-CoV, and now SARS-CoV-2 virus, which is responsible for the coronavirus disease 2019 or COVID-19. Symptoms are pretty much you'd expect from any respiratory illness. Obviously progressing to viral pneumonias and potentially in a number of cases death. There are no specific antiviral treatments. There are some in trial, things like Robertson, but there's no real proof that they have any effectiveness at this stage. So the treatment remains symptomatic management and supportive care. There will be questions around the vaccines. There are probably some useful candidates coming out, but I think the expectation is that we won't see a vaccine for about 18 months. People will be aware this originated in Wuhan city within the Hubei province. 30th of January, the WHO declared it as a public health emergency of international concern. And obviously we've imposed some travel restrictions on mainland China from the 1st of February. It has yet to be declared a pandemic by WHO. A bit of epidemiology. The figures around how many cases changes on an hourly basis, but it's over 82,000 now, nearly 2,800 deaths. Look, severity is mainly, there is a lot of mild disease, and particularly about 82% mild disease, about 18% get severe disease, around 4 to 5% probably require some form of intensive care. The death rate is probably around 2 to 3% for the case fatality rate. The R0, lots of predictions, but basically between 2 and 3, it's probably sitting around 2.8. So
that's the number of people who each case infects.
Yeah, right? So that's the reproductive number. So that's each person can infect 2.8, but we do get super spreaders in this. So that's an average. So some people are very effective at spreading this coronavirus, and that's not unusual in coronaviruses. Most likely transmitted by respiratory droplets, by fomites, and by contact. There isn't very strong evidence for aerosol pathways. Incubation period, we use up to 14 days, primarily between 2 and 10, and the mean's around 5.5 days. And as I said, case fatality rate is probably between 2 and 3%. It has been up until recently about 0.7% outside of China. Those figures are mainly from China, but we've seen, I think, in recent days, quite high case fatality rates in places like Italy and in Iran.
Is that because they're early cases and the system's not ready for them yet, or
yeah,
because the data might be wrong?
Certainly in Iran, I think they're not picking up the milder cases, and the first reports we had from Iran were 2 deaths, which was a bit concerning. Certainly, I think the figures are probably better in Italy, but there's still quite a lot, we're still getting quite significant numbers of deaths in Italy going forward. This is the Johns Hopkins CSSE site. Look, this is updated, almost in real time. This is from a couple of days ago, but it's a very useful site if you really want a good update of what's happening where, including the deaths that are occurring.
So that's if you Google Johns Hopkins CSSE.
Yeah, just JHU CSSE COVID map or something like that. You'll find it, and it's an easy enough website. People are probably aware we have 23 cases, confirmed cases in Australia. The initial 15 came out of Wuhan or were associated with Wuhan. There's a couple that were related. There's a cohort in Queensland that had 5 cases out of 9 on a bus trip. And then the remaining cases, the 8 cases, have come from the Diamond Princess, and these were amongst the 160 people who were medevaced from Japan back to Australia. So now we're at probably about day 7, day 8 on that group, and we haven't seen any more cases really since Monday. So I think we've probably passed the likelihood of getting more cases from Diamond Princess, but it does highlight that the quarantine on board the Diamond Princess wasn't as effective as obviously was hoped at the time.
How are they doing, those patients?
They seem to be all doing okay. I think it depends a little bit on the age of the patients. We've obviously got one patient here who's an elderly gentleman. He's still in hospital. He's stable, but we would be more concerned. He's probably one of the older patients that we're treating. So but he seems to be doing well, and his spouse is also still in hospital with him. And they're in negative pressure. We have been testing. So whilst the border restrictions are still mainland China, and people leaving or transiting through, we have been progressively expanding the people under investigation. So these are the people who we would suggest people might like to test. And that's now, we've got Singapore, South Korea, Japan, Thailand, Indonesia, Hong Kong and Iran. Italy and now Cambodia have been added to that list in the last 2 days. And it's basically if somebody has been travelling to those countries and has a clinically relevant respiratory condition, we would suggest that doctors consider doing a test on them.
It's getting to be a big list now. At what point do you say, look, if you've had any travel at all? Because they could have come across anyone at an airport in Dubai, couldn't they?
Exactly. And look, I think, as we start to see it, we are adding, and this has been the discussion at a national level, is when do we actually just say, if they've been travelling, and have a clinically relevant respiratory condition. I don't think, as you correctly surmise, I don't think that's far off. At the moment, we're at about 8 or 9, but I think probably by early next week we may well go to, if you've been travelling at all. We are continue to have pathways collection centres, and they seem to be working well. We've done 430 odd tests, which have remained negative, apart from one person from Howard Springs, and then it is a notifiable disease. So there is a requirement on all doctors to notify, and obviously on all the labs to notify any positive cases.
Just to clarify, at the moment, if you send off a test on a patient who hasn't been travelling, will it be processed by Pathwest, or will they say, no, we're not doing those people?
No, they now will do those tests. In the early stages, that was correct. So, we were screening them because obviously we were building up our capacity at Pathwest, and obviously we're getting a lot of negatives. But now, given the increasing cases around the world, anybody, basically, if they've travelled and they're clinically relevant, they're going to test them.
Okay. And if someone gets a patient who looks like they've got a community-acquired pneumonia, are we testing those people at the moment on the chance they could be the first?
Again, look, I think we're now at a stage where, if you're seriously concerned that they might meet the criteria, then we'll look at testing. We're not screening them anymore. So the public health units were screening them, but we're now, I think, at a stage where we have to accept that we haven't seen it. We're doing a lot of tests. We haven't seen it, and a lot more countries as illustrated, but we're not seeing it as it is at this stage from the testing. But we can't exclude the fact that somebody may have been in Italy, has come back a week ago, is now developed it, and people start to present in the community. We haven't seen that yet, but if you think if practitioners are, clinicians are concerned, then yes, certainly I think they should look at it. National response, a lot of this has been coordinated by the Australian government. We're meeting on a daily basis through the Australian Health Protection Principal Committee. That's basically the Chief Medical Officer and the Chief Health Officers from all of the jurisdictions. And then they are advising the national government, and that's led to the recommendations on a number of things, including activating various plans. So there is quite close collaboration through all of the through the states and territories and the Commonwealth government, and trying to get out the same messaging, whether it be on cruise ships, whether it be on what's happening with year 11 and 12 students. We're trying to have a consistent message based on that collaboration. There is legislation in Australia, and obviously in Australia, and also in Western Australia, so a lot of this is done under the Public Health Act, but there is other legislation that we may utilise. But we haven't had to use any of that legislation, but that does allow us going forward to quarantine or isolate people, to issue public health orders if required going forward. And that's something. And then obviously we're working more broadly with the whole of government, including Premier and Cabinet, on a whole of government response as well.
I suppose this is a concern for us in the non-Chinese environment, where the government is not going to be successful with a fairly coercive approach. So it's going to be really important to have solid communication with the community to get that buy-in from the general public. This is necessary, because you can imagine your average punter who's being told that they can't do what they want to do is going to want a pretty good reason for that, and we might not have the same ability to back it up with force to get people to cooperate with quarantine and that sort of thing.
Yeah, and look, and I think we do have the powers, and certainly under the Public Health Act, we can enforce it if need be, but obviously in the first instance we're keen make it clear what isolation means, and not that doesn't mean that people can go off to the shops, or go to football, or whatever the case may be. It has to be very clear that that means we're staying at home, and that it is a benefit not only to them, but obviously their workplace and their families.
Yes. We're just being asked, in terms of those countries that people have travelled through, if their result comes out negative and they've got a respiratory illness and they've been to Italy, are we advising that they should be quarantined for 14 days at the moment?
No, we're not. So if they, as you can imagine, they're coming out of the Northern Hemisphere, there's still a lot of respiratory illness in the Northern Hemisphere, so there's flu, RSV, a number of others. Look, obviously we recommend that they stay at home while they're still unwell, but there's no need to quarantine them if they don't have COVID-19. So this was just to say, look, we still are very much in the containment phase in Australia, not necessarily the case in other countries, but we have now moved over the last 2 weeks into the pandemic planning. How do we plan for our hospitals and what we do? So we'll look at, that's what we're currently planning for at the moment. From a health point of view, as I said, this has started to work on things like fever clinics. These we're calling COVID-19 clinics. We're doing a lot of work with the ICU and our emergency departments and other departments within the hospitals as to looking at their capacity and capability. Obviously, we know what negative pressure rooms and cohorting room areas we have, so there's a lot of work going into that. There is a lot around the management of supply stock, around appropriate use of masks. And then obviously we're looking at our workforce and how we best manage that going forward.
Just before you go on from there, because I've got a lot of questions around these things, which I'll tell us as much as you can.
Sure.
We're seeing some pretty big numbers being quoted in terms of the number of people who will need to be admitted to hospital if this affects sort of, 50% of the population, then 10% of those need to end up in hospital. Just the basic capacity of the whole system, is there plan for increasing that?
And that's a lot of what this work is around. So it is around, look, I think we have to be a little careful about jumping to 50%. I mean, most of the modelling would suggest around 25% hit rate, rather than 50%, but appreciate that's very much a worst case scenario. But even with 25%, that's still a significant part of the population.
It's still tens of thousands of people in Perth at some stage during the pandemic needing some sort of fairly acute care.
It is, and so a lot of our work is really focusing on how do we improve the capacity of both our emergency departments and whether we can divert patients, because 80% will still be, well, have some disease that would be mild, and so obviously getting them home is critical, and working with the community to understand that people going home is actually protecting them. And then obviously the more broader one is how do we address those more serious ill ones? How do we increase our capacity of our ICUs? How do we increase our capacity on the wards? How do we work with private hospitals to look at maintaining some services?
That is business as usual.
Yeah, so the business as usual, particularly there's always going to be traumas, there's always going to be, coronary events, there's always going to be the whole range of things that mothers are still going to be delivering babies and all of that. How do we continue to protect some of that business as usual? Yes, it will probably impact on things like elective surgery, and there may well be delays in that because they do have an impact on our ICUs. So we do need to look at that, and how do we actually continue?
Yeah. So have you got are you able to talk in sense of scale, like how many more ICU beds we might need if this is mild, medium, or bad?
So there is some discussion. There's some modelling, early modelling, which suggests that we may have to look at doubling our capacity of ICU beds. Now, that's capacity, and so obviously we can. Some of that will be achieved by obviously looking at elective surgery, by looking at what operations we're doing. There are stuff that we do that can be delayed or postponed, but it also is how do we improve our capacity across our hospitals, creating alternative ICU areas, those kind of measures as well. And that obviously requires equipment and staffing and consumables and all that stuff. So that's a lot of where that focus is going into at the moment.
And so you're going to want to keep that 80% of people with relatively mild disease in something like a fever clinic or a community setting, and how do you see that interacting with general practice and EDs? Do you think patients will avoid general practice and EDs and be going mainly to these centres?
Look, I think that will be the intention, but we also accept, and we've had some early discussions with WAFA. We're hoping that in the next week or so with the College of General Practitioners, with AMA and WAFA, is to look at, there may be practices, GP practices, that are quite happy to see these kind of patients. And obviously we don't want to exclude them if they are, while other practices will want to just be seeing business as usual. We need to maintain that business as usual as well. But we'll be very happy to work with them, but a lot of the time, I think a lot will go to the COVID-19 clinics. Now they may be situated near EDs, or they may be situated, externally in community centres or things like that. It will depend a little bit on the model. What we're trying to do is protect both the GPs and the EDs so they can go about their normal business. And the only patients that are entering hospital will be those ones who are more serious patients who obviously need some hospital care.
So for those of us who have a hospital base, we would be expecting to hear plans about that sort of very soon as to our workplace and whether one hospital is going to be taking a different role in the system.
Yeah, and we're starting to have those discussions now as to what is the role of each hospital. How do we, we obviously want to protect some of our services. We have some very important, burn service and things like that. We want to obviously need to continue to operate those, and how do we?
And you'd want to be isolating those patients as much as possible, obviously.
Exactly. And how do we, have maternity services? How do we deliver those? Accepting that some of the mothers, mothers to be will actually, may have the coronavirus. So how do we protect them and staff that are involved?
And there's the children's hospital as well, of course.
And there's the children's. Although interestingly, we're seeing very little disease in children. It's so there's something, whether they're getting very mild disease or not, but literally 3% of the cases are in children.
They're probably just spreading it around and not getting sick.
They may well be, but they're not. Yes,
5 months.
And none of the deaths have been in anybody under the age of 10. So
some good news in all of this. In terms of PPE supply stock now, are we going to be, there's questions around what to do with my general practice if I have no gear and no chance of getting any gear, but I suppose, are we all going to be moving into a post-traditional PPE world with this if it ramps up?
Probably. We've been looking at our things. The reality is, despite what people may want, the masks we have are the masks we have. There is no supply coming out of much of the world. So obviously China was the major producer of masks. Now so for example, within the department, we can, at this stage, we're able to continue business as usual, but nothing beyond that at this stage. And that's likely to be the case for some foreseeable future. So while a number of people are saying, can we provide them with masks? There is no current way we would be able to provide them with masks without stopping services within our hospital system. Now, that's not to say we won't look at whether there are alternatives, including how, whether masks are required, and if we can actually look at reducing the use of masks even within the hospital setting, then that's something we will do. But obviously we need to make sure that we continue to protect staff and not, but we need to keep those masks for those who are really dealing with the higher risk patients, including those likely to come in at some stage of coronavirus.
And that's where something like a fever clinic makes a lot of sense, because if those people have the right
so
care, we divert them away from the
exactly. So in a fever clinic, we can bring them in. We have the people. It's an effective and efficient use of what resources we have, and then we get those people home. And once they're home in home isolation, if they're mild, then see the demand on masks is smaller.
A couple of interesting questions on the chat there, and feel free to put your questions in the chat. We'll try and get to them if we don't cover them in another item. But can we foresee patients self-testing if we have training with it and online and kids going out?
Look, I think there's certainly kits that are becoming available. I mean, it's still early stages, and a number of them have been obviously pushed through early on, so all of our public health laboratories can do the testing. But certainly we've already been in discussions with other countries about possible kits. And look, I'm not sure we'll get to the pregnancy test type sort of scenario yet, but certainly, look, I think there will be a lot more use of those. One of the other things that we are already doing, and we will look at whether we can expand that service, is to domiciliary testing. So rather than people coming in, sending people out to actually test at home. So we're already doing that on weekends through CliniPath, but we will look at whether that's an effective way, because it obviously stops people. They can remain in their home if they're not seriously unwell.
Okay. And if a person's been in contact with a confirmed case, I imagine once we get into pandemic level, we're not going to be contact tracing. Is that right?
Once there is established community spread, we won't be, I mean, in the early stages we may. So if in the early stages when there's just, small numbers, a bit like the Italians, we may try and contact trace. But once it's widespread in the community, then we get to a stage where we probably won't, we may have stopped testing. We may actually, it may be done on clinical grounds. So if something comes in, we may have actually say, look, we think you've got COVID-19 and go home.
Because at some point we could well run into flu season as well.
And that's going to
complicate matters.
That will complicate matters. So from the modelling, we don't know when the peak will be, but certainly that is a possibility.
So when you do have a contact in your general practice, the family members and so on, should they be tested at 2 to 10 days? At this point in the cycle, what are we doing about contact testing at the moment?
So if we have a confirmed case, then close contacts we would test at this stage. And obviously, but again, the problem with testing is, you can be a contact until, probably a day before you become symptomatic. You may not have a big enough viral load to be picked up on the test. So there's probably limited utility doing it too early. Okay. But certainly there is tests. I see there's one question around national stockpiles.
Yes.
Look, there are national stockpiles of masks, both surgical masks and P2N95 masks, but those stockpiles are not massive, and basically they're designed to really support the health system when we get to that real stage where we may be starting. As I said, we have enough masks for business as usual at the moment, but once we need a surge capacity, and that is largely our surge capacity at this stage.
So for people in general practice, I think they can safely assume that a workable supply of N95 P2 masks is not going to arrive at this point unless China gets production back going. We have heard some rumours that the Chinese are starting to ramp up production again for some of these.
Look, I believe that they are, but a lot of their demand is going into their own, into their own economy initially. And look, I think the other thing is that we have to look at the use of masks. The recommendation still for the Communicable Disease Network is that unless you're seeing a patient who is coughing or spluttering, or you're doing a respiratory procedure like putting a tube down, then there is no requirement for you to have a P2N95 mask in a general practice. The surgical mask is adequate.
There is a lot of other practice outside hospitals that involves those, outside the public hospitals that involves those sort of things though, doesn't it? So
there are, and obviously you have to look at what those are and if they need to be done. And there are obviously high risk respiratory procedures, and obviously in those circumstances, intubation and things like that, yes, you would, then having an N95 mask. But again, N95 masks, P2 masks require some fitting. If you don't put them on, they're probably next to useless. And
they have a limited duration of action. So what I'm hearing is that even if we distribute the entire stockpile, we start using them in the first week of a pandemic or a big number of cases in the community, we're going to run out of them anyway.
Yeah.
So we need to have alternative ways of either handling these patients or some sort of MacGyver solution to what we're going to use for homemade viral masks.
We certainly need to be very studious in how we use these masks. We do need to preserve them because there will be, people have seen the figures, we are going to get seriously ill people. We are going to get people in intensive care, and we need to be having the masks to manage those patients. Otherwise, understandably, we won't get any staff who will manage those patients, and that would be a awful outcome.
Well, it's going to be difficult, particularly because we would expect some of the health workforce are going to fall ill with this as well.
And it's going to be hard anyway. That's right.
So trying to ramp. So presumably we're going to need to extend do what we can with the staff that we have, and that's going to, we're going to need to provide strong mental health and workplace support for people who are suddenly finding themselves in a situation where they're used to it, looking after one acute care patient, for example, and they may have several.
That's right. So we may, part of this will be looking at our workforce, how we can utilise workforce, people who are maybe part-time now, coming on full-time for a period, people. So it's going to be an interesting period going forward, but I think they're the kind of considerations we have to start thinking about how we actually get that workforce.
Okay, I'll let you finish your slides and then we'll get back to some more of these questions.
I'm already close to.
We're here. Presentation and into the
question and answer.
Into the actual question and answer, so we're doing okay. The next question that I've got on my list here is we can cover all of those ones. What should we advise about further flight restriction? Will there be any further flight restriction in your view?
Look, the recommendations currently is that we don't restrict further. Obviously, it is a change in feast, but there is only limited utility and only probably for a limited period of time for having restrictions on flights. So I think we're at a stage now where we're basically saying this, I think, as indicated earlier, that if we're at a stage where travel, we should be suspicious if they have respiratory illness, serious, significant respiratory illness, and they have been travelling, then we need to get them tested. So it's more around, let's look at that suspicion and do the earlier testing rather than relying on closing the borders, because that's not without its problems.
And what should we be telling patients who come in and say, I'm going to Bali or I'm going to travel?
That's a harder one. Look at
particularly people with comorbidities, I suppose.
Yeah, and I think people have to make that assessment. I mean, if you are, unfortunately, what we're seeing with this disease is it does seriously impact those over 65, and certainly the case fatality rate, while it might sit around 2 to 3%, is considerably higher in those over 65 and certainly those with comorbidities. So, if you've got elderly patients who are doing, it's a holiday and they're intending to go to any of the higher risk areas, then, I think they need to have a serious consideration as to whether this is the time to go. I appreciate there are other times where people have to go for family and other reasons, but I think people need to start looking at the risk. And unfortunately, that's getting broader and broader each day.
Just back to, there's a couple of technical questions there as well. In terms of the sensitivity of the test, if you get a negative test, is that a good sign the patient who has an evolved disease hasn't got it?
Yeah, if they're symptomatic, yes. So if they haven't, they're probably, they've probably got another respiratory virus. So look, there has been 1 or 2 cases where people have ended up with both having flu and coronavirus at the same time. So, it's seriously unfortunate if that happens. But yes, usually it's at this stage. I think you can, if they're negative, you can assume that some form of other respiratory illness.
Okay. And chloroquine, have you heard much about the chloroquine discussion? The Chinese seem to be they've had some success with it.
They are, but it's not on its own. Generally, I think it's in combination with a couple of the antiretroviral, antiviral agents. So they were experimenting. So it's more as an adjuvant for those. But again, it's still early days. We haven't really seen any proof as to whether it will, affect the course of the disease, whether it shorten the disease, what impact it may or may not have.
Okay. We're obviously going to have some vulnerable healthcare workers out there because of their own comorbidities. They might have been on chemo recently, or they could be pregnant, or they might have respiratory disease themselves. So we'll need to have some process in place for looking after those workers as well, won't we?
We will. So some of the discussion, and it's certainly within health, but broadly across government is how do we manage patients who are, who may be very susceptible, for the various reasons, autoimmune diseases, a number of other reasons, and looking at other options so they reduce. So can they work from home, for example? That may be practical for some, some roles, but obviously it's a bit more difficult for some health roles.
Okay, we're going to have room for a few more questions for the people listening, so if you've got something, please send it in for us. In terms of this idea around the hospitals and the current patients they're treating, the ones who might be immunosuppressed or turning up with other comorbidities, is it likely that places like Fiona Stanley will establish a separate location for dealing with coronavirus patients?
Well, Fiona Stanley obviously has a number of negative. They have over 40 negative pressure rooms, so they can certainly in the first instance manage those patients.
Charles Gardner doesn't have that many, does it?
No, it's got I think 4. And they also have the ability to cohort some wards. So they, if we get above a certain number, we can put them into one, into one ward.
Mm-hmm.
So that will give us, to a certain degree, that will help us at least in the first instances. However, we will get to a stage where the numbers are beyond that, and we will then need to look at whether we look at wings of hospitals, whether we look at dedicated hospitals, those kind of things.
So that's the kind of work that's being done at the moment in preparation. There's a fairly straightforward question here about what's involved in the actual testing, especially if it's a sick child. Is it nasal swabs?
Nasal swabs, yeah.
So it's all nasal swabs, and they do blood?
They do some deep throat swabs as well. There's no blood, there's no serology at the moment.
Yeah.
There is some work on serology. Serology, to be honest, there's not an urgency for serology because it's useful looking backwards, but it's not going to be particularly useful at this stage. So it's more around getting an acute test for the disease.
There are a couple of interesting issues to do with the immunology of it around the vaccination and whether or not the immunity will persist, because we don't really know yet, do we? Whether it will convert to a long-term immunity to this particular virus.
Yeah, there has been some speculation around whether it will, what protection you'll get from either a vaccine, and for how long, what protection you'll get from natural disease as well. So again, it's probably still early. We don't actually know that whether people.
I suppose as a community, even if the immunity fades, as long as you've got some people out there who have some immunity to it, then that's better than the situation.
It is, and at least, and often if they're re-exposed, they may, and they've already been primed, they may have some protection going forward.
And it's my understanding that nothing particularly useful has ever come from using convalescent plasma or trying to find IgG.
That's correct, yeah. So a lot of the work has been done on SARS-CoV and MERS-CoV, and there doesn't appear to be a role particularly for convalescent plasma, particularly in the treatment. There has been some suggestion about its use in a prophylactic way, but again, I don't think there's too much. It's an interesting proposal, but I don't think the science is too much has been yet determined.
And I suppose the other thing we don't know is whether this might end up like influenza and be a mutating virus, or is that unlikely?
Look, I think the coronaviruses will mutate. So, but they, and so if you look back at SARS over the couple of years, 3 or 4 years, SARS was around. It did mutate, but it didn't. Interestingly, the mutations didn't have a marked impact on the actual virus itself in either its transmissibility or its virulence, so they were mutations strictly, but they didn't actually impact on its. And hope, we know this virus will probably mutate, but we hope obviously that the vaccine may be preventative against it. It was not like a flu virus.
SARS seemed to transmit well in the medical environment mainly rather than in the community.
I think there's a couple of factors there. One was the some super spreaders who were very effective at spreading it, and two was the use of protective equipment. So we're talking about masks, but this was basically people not having any masks who were managing some of these patients. And obviously,
I can hear our GPs out there going, yeah, well, that's me at the moment. That's how I feel funny in the headlights with this coming up.
No, I'm talking about people treating in hospitals.
Intensive care patients.
Yeah, talking people on the wards we know have coronavirus, not people who have a sniffle and may have been overseas.
Okay. Although the sick patients are going to turn up somewhere, aren't they? So that's
they will.
Why public education is going to be important about where to go. And I think at this stage, the AMA would be saying to general practices, you need your communications in place. And if there are patients turning up and we start to see this in the community, then you need to consider whether your practice is capable of dealing with them in a physical sense.
And there has been certainly surgical masks provided to the general practices through WAFA,
yes.
And that came from the national stockpile, and that was really intended to at least provide some initial ability for people to, if they do get patients that they're concerned about, that they can put the mask on. Now, I appreciate the initial amount was small, and there may be more.
You can't really reuse them a lot, can you?
No, you can't.
That's another question.
No.
They're pretty much a one-use item, and there's limited efficacy after a few hours with most of them.
Yes, that's right.
Yeah. Okay. In terms of emerging effective treatments, I think one of the HIV antiretrovirals is looking a bit positive.
So there's a couple. There's a couple of the retroviral drugs. They're older retroviral drugs, and they thought they may have. And then there's another drug called Recidivir, which is a it's not a registered drug here, but it is seems to be reasonable quantity. So there's certainly a number of studies in who they probably looking at those. But again, we haven't even seen early information on what the impact of those drugs is.
So in terms of, we've already said we think vaccine probably 12 to 18 months before community level. And how would that be rolled out? Would it, once vaccine becomes available, presumably it would go to high-risk exposed healthcare workers first? Yeah,
look, it will probably go, I mean, it's a bit like back in 2009 when the first batches came out of the H1N1 vaccine at the time. Obviously, we focus on those at highest risk, and that is usually the healthcare workers who are managing patients, and then rolling them out broadly across the community into vulnerable groups and who may be more susceptible, and then obviously more to the general population.
As I understand it, the two aspects of the vaccine are you've got to have check the safety and see whether it works.
Exactly.
It takes a little while.
That's right. So
is it still injecting eggs? You still.
Look, there are some newer techniques, but certainly that's the obviously for influenza that's still the major things. But there are I think there are emerging techniques, and it will depend a bit on this virus as to what's the most effective.
So we're just hoping that those people in Queensland are as clever as they keep telling us they are.
Let's hope so, and if they can find a viable option, that's great. But as you say, there's still the safety testing and all of those kind of testing that still needs to go
on. There's another basic question around what do you tell someone who's tested positive, they got mild symptoms, they're travelling okay, and you're sending them home. Do they have to stay away from everybody?
Well, they should. Yeah, well, they should certainly stay away from as much as they can. So, isolation would be staying in a part of the house. Social distancing becomes an issue here. It becomes a thing. How do you? I mean, we're having this discussion with about school children coming back, and how do you keep them distance from a host family or things like that. And again, there are ways of doing it. Keeping people at least a couple of meters away, those kind of things. Putting arrangements in. There may need to be arrangements placed in for food, feeding people, and obviously have access to toilets.
Right. So, and impressing upon people the seriousness of that, I suppose, particularly with the vulnerable family members until we get a treatment or a vaccine, or particularly if there's a high load going on in the hospitals at the time. So, has there been much talk around the communication to doctors in the community? I mean, we're just getting used to the fact that, I mean, you and I can do a few more webinars and things, but in terms of getting that two-way communication going about what's happening, that'll obviously have to be ramped up from the government side as well, so that the population doesn't start panicking, really.
Yeah, look, there is a lot of communications out there. I mean, the amount of stuff that's now on our website, on the government's website, the Australian Government Department of Health website, WHO, CDC website, there is a lot of information that is up there, and a lot of it's, we regularly send out clinical advisories out through to all of the general practitioners. I think we're sending too many at stages, but they will continue to ramp up as we continue on. These are obviously very useful events to link in with other portions of the population. So yeah, certainly that will continue, and yeah, I think you can see it ramping up to another level. But there is already a lot of information out there.
Okay, and are the states each managing this independently? So if we get to a point where, say, Victoria's got an awful lot of cases, are they going to be relying on New South Wales to help them out, or is it essentially we're just going to let the states handle their own business?
Look, we're all in this together. I think it's, there's a lot of national coordination and trying to work out, most of our the guidelines and everything else are consistent across the board, and we really have to work on how we to do it. So look, there will be variations, and that obviously we are also subject to our state governments and how they want to approach.
And our isolation here, of course.
And our isolation.
We don't really have the option of sending sick people elsewhere. I suppose it's for, although we did bring one patient back from Darwin, clearly that's part of the deal, is that we look after our own people.
And that's right. So we will look after our own, but obviously we will assist where we can. So we actually provided doctors and nurses into the OSMAT teams that went to Christmas Island and to Howard Springs. So we will provide support where we can for the greater good, but obviously we have to look after our own, and if we can help our neighbours, then we'll do so.
Do you have a sense yet with a hospital in the home? Sorry to jump around with these questions, but do you have a sense yet with a hospital in the home type services will be sophisticated enough to offer something like oxygen, or for people who need that higher acuity care that would normally be done in a hospital?
Look, yeah, it's a good question. We've been talking to a number of those agents. We've talked to Silver Chain to look at what kind of care they can provide. But yeah, it's certainly they will be on our list to look at what we can, kind of support we can provide.
And presumably, as we find out more about PPE, or people come up with alternatives to what we've traditionally used, or I'm sure there's a lot of very clever general practitioners and other doctors in the community who are thinking about how to adapt their practice in a way that might provide safety for them and their staff. Obviously, you'll keep that kind of communication going about what's coming down the line.
Oh, certainly, yeah. Look, as soon as we're working, our supply people, as I'm sure other supply people, are looking at options all around the world for improved. And we talk a lot about masks, but unfortunately there are other supply challenges as well. We have become very reliant on the Chinese markets, and that. But as soon as we have availability, we will let people know.
Okay, folks, we're going to wrap it up fairly soon. So if you've got one last question, then please fire it off now. I guess my last question coming from me is around. This might not be the last time this happens. Hopefully, it'll be the last time it happens for a few years. But what will we do differently for next time in terms of preparedness apart from hoping that someone in Osborne Park sets up a N95 mask factory so we can all have some at home.
It would be kind of nice not to be as reliant as we are on
the country of origin of the virus, yes.
On the rest of the world in this space. But look, I think there has been some questions about national stockpiles and things like that. Look, I think we've had a little bit of a perfect storm in the sense of there was a lot of masks that we used in the fire, in the bushfire response, and that was obviously to provide support to the general public. And there were quite a few million masks that we used in that response. And look, I don't think, and everybody was anticipating that we would be able to bring our supplies back up straight after that, and obviously to be hit almost straight after with this event has left us in a more vulnerable position. So obviously we will continue to maintain the mask stockpiles, and I think that is an important thing. But I think we've learned a lot from 2009 and 2014 with our preparations for Ebola, and so I think we'll continue to build on those lessons.
And is there a sense amongst your cohort of college people working at your level that a national CDC, a formal national CDC rather than a working group would be a good thing for the future?
Look, it would have to be. I mean, it's one of those things that I think there are benefits in a national CDC thing, but there are also challenges that would have to be worked through, and some of those are that we are very much a federated system, and every jurisdiction has different laws around public health, around medicines and poisons, and so you would have to work through many of those challenges as to how it would, is it just an advisory body? Is it going to have power to direct?
Yes.
How does that actually work in a federated system where ultimately we are answerable to our state governments,
and the states have the money for health,
and we are funded for the health. So it's I think there is certainly merit in the option, but the devil really will be in the detail as to how that would look going forward.
A couple of quick questions that both have the word 14 in them. What do you think about, in your sort of looking at all of this, what do you think about the 14-day quarantine with reports of longer incubation?
Look, the evidence for longer incubations are not strong. So, the 27-day one was based on one case, and obviously there's some skepticism as to how that was, how realistic that case was. But I think, but obviously we are continuing to monitor. There may be a couple of outliers, like any spread of incubation period. There may be outliers, and obviously we'll continue to assess and see. But certainly, from our experience, 14 days has been more than adequate.
And do we think that we need to give certificates to people because there's a bit of horrible racism and some prejudice going around the community? There will be presumably workmates who find out someone's off with this and unhappy about it. So what kind of documentation should we be giving to people? Because we're using the term cleared the virus. I presume they're not being tested again at the end, are they?
Well, they are at the moment. So the people who are being discharged from hospital usually will have had the current national guidelines is that obviously they're asymptomatic, but they will have also had 2 negative PCRs 24 hours apart. So they are really, in essence, not showing any viral load. So they are being cleared, and that we can give people, and certainly we've done it with the Christmas Island and the Howard Springs. They've been given a medical certificate to say they've done their 14 days. I mean, I think the ones who have been treated is one thing. We had a bit of some craziness where people were saying, well, you can't go into work until you have had medical clearance. And this is from people who come from almost anywhere in Asia. That doesn't actually make any sense.
Yes, because they could be pre-developing the problem anyway.
Exactly.
Okay, and in terms of future supplies of PPE, obviously there's going to be a much greater stockpile that we're going to need going forward. So that'll be part of the wash-up investigation into all this. Hopefully not a royal commission, but looking back and with a bit of luck, we'll be able to say how lucky we were this time around. Is there anything else that you think that our doctors online should be aware of that we haven't covered to this stage?
Look, I think we've covered a fair amount of material over that period, over the last hour or so.
Yep, and I will reassure people that if there's other people you'd like to show this to, we will be making it available online for people to watch later. And we'll also be publishing some of the results of these questions, but I think importantly, and in the department are keen to communicate, and we'll use this means and others that we can as we go forward. One last question there. What is the time frame between the two clear swabs that you mentioned?
Usually 24 hours.
Okay, so 24 hours. So that's finishing off on a good practical point. So no doubt there'll be lots more practical questions. I think the message from the AMA to our members will be that we will support you to feel comfortable in your practice. None of us are going to be very happy about this happening, but doctors need to be sure that they will be supported. Where we don't have the right gear to do our job, then we need to make an assessment of how we can get around that altogether as a community. No one should be putting themselves in the way of danger. If you don't feel that your practice is set up to handle these patients, then we would support you diverting people and seeking advice at this stage. We wouldn't encourage people to be just deciding it's all too hard and put a sign up out the front saying go away if you've got a fever at this stage, but we would be saying put a sign up saying if you've got a fever you need to talk to us on the telephone before you come in here coughing, and how we deal with it from there. We've got to work together as a medical community.
And I think, and it very early, and that'll be one of the probably the earlier decisions is around the use of fever clinics and where appropriate, to set those up, so that we do provide options, so they don't, don't have to go into GPs, that they do have an option.
And what will that look like? That could be anything really, I suppose.
It could be a part of a hospital, it could be a demountable, it could be a tent, it could be a community hall. It's primarily for assessing the patients. Obviously, if they do have a disease and they're mild enough, testing those patients, and then getting the ones who can home. Obviously, there will be a percentage who may need further care in our hospital system, but are able to then get them into the hospital system without placing additional strain on our hospitals or our EDs.
So despite whatever headline the West Australian choose to run tomorrow, we should be saying that people, obviously we never encourage panic, but we do encourage preparedness.
Yes.
That the health department are well aware that we may end up with many more thousands of very sick people that we normally deal with. And that whilst we're not able to unveil the full set of blueprints right now, there's certainly people in charge are working towards some very fine detail on the planning. Yeah.
And that will be in the next couple of weeks. That will be cranked. I mean, that's already been running for quite a long period of time. That initial work, but it will be obviously as over the next few weeks that will be continuing to crank up and a lot more interaction, particularly with the hospital sector, but also importantly all of the other sectors that feed into.
Andy gets contacted 24 hours a day by the health minister, so we won't give you his mobile number, but I'm more than happy to be called, contacted, texted, emailed at any time, and I can certainly ask Andy a question when the time's appropriate. He's trying to have his sandwich, and we want to keep the lines of communication open, so don't hesitate to contact us about that. We've gotten to the end of our allotted time. We want to respect everybody's evening, and we thank you very much for the time that you've given us. So but it won't be the last time we all get together to have a chat about this. By all means, get in touch in the meantime. And thanks for your attendance on the webinar tonight. On our website, we'll put up the details of when and where it will be available online. Thank you very much. Thanks, Andy.
Thank you.